So do you think, Tiffany, that we now have a new subset of breast cancer? Is this like a new type of breast cancer, the germline BRCA? We need to be looking at it differently, prognostic-wise, treatment-wise?
Oh, great question. So I think we've all been grappling with and recognizing the heterogeneity of breast cancer and even triple-negative breast cancer. And we've had groups look at molecular characteristics and classifications for TNBC. I think we've all suspected there was a subset of triple-negative breast cancer in particular that behaved differently. In the Pete and Pohl subset, these were the more basal-like, highly proliferative tumors. And I would say yes, we now can carve out patients that have a germline BRCA mutation as now an actionable biomarker. So while it certainly has implications in the early stage setting for risk-reducing interventions, it is now an actionable subset of breast cancer. And so in my paradigm now of approaching a woman who has a diagnosis of breast cancer, as I'm trying to think about a treatment plan, I feel that I need to know the germline BRCA status to make those appropriate decisions. In terms of prognosis, I think the data, largely from retrospective series, has been somewhat mixed. And I think at best we can conclude that the prognosis is really comparable, whether you have a germline BRCA mutation or not, once you have adjusted for other known prognostic factors.
Yeah. Yeah. Do you agree?
I would absolutely agree with that. Absolutely.
And you think of BRCA as a new kind of fourth subtype, if you will. Well, maybe we've got four. We got luminal A, we have luminal B. Those are very, very different biologies, So you think we got a new subtype of breast cancer here?
I think absolutely, and I think it's important to really focus your thinking that way so that you don't forget to do the germline or the somatic testing, both for treatment, as we're going to talk about standard treatment, but also for trials and PARP inhibitors. So I think if we can think about the different subsets with BRCA as a separate, it will help us.
Because even regardless of any family history whatsoever, what's the chances we're going to find a BRCA mutation in somebody with Zippo family history? Here they are in the metastatic setting, triple negative ER positive. What's the chances we're going to find it?
Yeah, well, I think there's some difference in data. I think what we've learned, for example, in the Ashkenazi Jewish population is that half of the mutations we're finding in the general population are patients that don't necessarily have a personal or family history. But if we're thinking in breast cancer, clearly there are some groups that are enriched for this. Triple negative breast cancer, younger age, again, Ashkenazi Jewish. So I think if somebody has an extremely large family and no family history, certainly the chances are much lower. But I would say again, in the metastatic setting, if you're doing somatic testing, you may pick them up. But otherwise, I think if you would use the PARP inhibitor, it's worth thinking about the germline testing.
Because I've seen estimates up to 11, 14% for TNBC. Yikes, that's pretty high. And I've seen estimates as low as 5%, though. Too. I guess.
I think it's between 10 to 20% for triple negative. I really do. I think unselected all breast cancer, we're talking 3 to 5%. But for triple negative, it's between 10 to 20%.
Yeah. So it is something, and we don't want to miss it because we're just at the tip of the iceberg. We're just starting down the road of how to optimize the treatment for these patients. I guess another question is we do find these variants still in the germline, less and less with the BRCA1, 2, maybe more and more with some of the other germline, which we'll come back to. But would I be wrong if I had a patient who's got a strong family history that's kind of suggestive of a germline mutation, but she just has a variant that truly is unknown at this time, and now she's got metastatic disease? So she's kind of acting. Let's even make her triple negative. Would be wrong to give her the benefit of the doubt and treat her with olaparib? What do you think, Tiffany?
Well, a patient like that would not have been included in the 2 big randomized phase 3 trials that have reported out data. So I don't know that we have evidence to support that there would be a benefit for that particular patient. I could sense why it's so compelling to think about an attempt there. But I guess I would say, since there are several recruiting trials for PARP inhibitors in metastatic disease, I would favor that approach first so that we could try to learn something from the experience.
I agree completely. I think we don't want to get away from the message that VUS really, most of them, 85% of them are not going to be pathogenic mutations at least. So I think we shouldn't be treating them like mutations.